Having us today. I am here with my colleague, Sneh Parikh. Today, we will be talking about the surveillance program here at the DC Department of Forensic Sciences, specifically the chemical analysis and monitoring of drug residue in needle exchange syringes in Washington, DC. So just a brief overview of what we will be discussing today. We will first talk about our surveillance program as a whole, because although our program emphasizes a lot on our needle exchange syringes, there are different aspects of our surveillance program. It's actually a very comprehensive program, and we will talk about the other aspects in some of the later slides. Secondly, we will talk about the different technologies and methodologies that we use in our chemical testing in order to detect controlled substances in our samples. And then lastly, we will talk about the role that our data plays in public health and how we can use this data to inform our public health partners in overdose prevention initiatives. And also how we are able to make an impact on legislation. So this is an overview of our drug surveillance program. There are many different aspects of it, mainly coming from the source of our samples. So the first is our seized drug supply. These are evidence samples that are collected by local law enforcement agencies, such as the Metropolitan Police Department, DC Department of Corrections, or the US Capitol Police. Secondly, we have our drug usage data, which comes from our needle exchange syringes. So we have partnered with 4 different harm reduction agencies that run needle exchange programs. And in these programs, drug users are able to exchange their used syringes for a clean syringe. And that's to prevent the sharing of needles and the spreading of bloodborne diseases. And so when those syringes are collected, they are submitted anonymously to us so that we can test the syringes for any residue that's left over in those syringes, and we see what drugs are present. So currently we have partnered with Bread for the City, Family and Medical Counseling Services, helping us people into living, and last but not least, honoring individual power and strength. Third, we have our clinical monitoring. That includes our toxicological testing. We are currently in the process of bringing online a biosurveillance program testing blood and urine samples that are collected from overdose patients at local DC hospitals. We've also previously tested urine samples from buprenorphine and methadone addiction treatment programs, although that program is no longer running. Fourth, we have our overdose data. This is also syringe data, but these samples are collected by the Office of the Chief Medical Examiner during death investigations. So that gives us a picture of lethal drug trends. And then that finally brings us to the last step, step 5, what do we do with this data? One thing that we can do is make an impact on drug legislation. Locally, we have the Safe DC legislation, which schedules drugs based on their drug class rather than their individual identities. So by making changes to this, this legislation, we can schedule drugs before they are federally scheduled, because it does take some time once a novel substance is found. This is a brief overview of our testing. So we analyze all of our samples for the presence of CDS, which stands for Controlled Dangerous Substances. So that means anything that's federally or locally scheduled. We also look for other substances of interest, and that can include things that may or not be psychologically active, and also might not be scheduled. That includes things like cutting agents, adulterants, precursors, byproducts, or any other additives. And so the types of tests we perform are listed here in this slide. We have our presumptive tests, which are the non-specific tests. That includes color tests. You may know that may be known to you as typically field tests that are performed by law enforcement on the field when they collect these samples. We use pharmaceutical identification for pills. We use microscopy specifically for marijuana. And then lastly, we have our analytical instrumentation, which provides more specific information about the samples. That includes gas chromatography, mass spectrometry, gas chromatography, flame ionization detection, and FTIR, which stands for Fourier Transform Infrared Spectroscopy. And some of these analytical instrumentations, they actually provide data on chemical structure, which presumptive tests cannot. This is a picture of what our surveillance program can accomplish. With our syringe analysis, that gives us a near real-time picture of what's currently in our drug supply. With evidence that's collected, it's not possible just because just the intake procedure and evidence transfer procedure that can take months between collection and analysis. So that doesn't really give us like a real-time picture. Just in a matter of months, trends can easily change very drastically. So this is a very important aspect of our needle exchange syringe analysis. With death investigations, we are able to compare lethal drug trends with the non-lethal drug trends that is provided by our analysis of needle exchange syringes. And then with seized drug surveillance, that fills kind of a gap that we have in our syringe analysis because through our needle exchange program, we are only looking at drugs that are injected. With seized drugs, we are able to analyze drugs that are collected in all sorts of forms, such as pills, powders, plant material, liquids. So that provides us with a more comprehensive picture of what's in the DC drug supply. With that, we have previously been able to look at trends in counterfeit pills. Counterfeit pills are pills that appear to be legitimate pharmaceuticals, usually oxycodone, but with testing, it shows that a different substance is present, and that substance is almost always fentanyl. So we have previously been able to publish a manuscript looking at the trends in the different imprints that we see and the different substances that we see and the likelihood of different imprints being counterfeit. And then lastly, we've also previously been able to assess hair impurity and changes over time.
First and foremost, excuse me, thank you so much to Lucy for that wonderful overview of our program. My name is Sneh Parikh. I oversee the grant-funded surveillance activities. CDC provides us with a certain amount of funding per year, and DC Health, by extension, supports this work that we do monitoring the illicit drug supply. I also want to say big thank you to DCHA, specifically Alicia and Eden for having us today. And wonderful insights from the Office of the Chief Medical Examiner. I think you'll see in a short while here that our data very much aligns with the insights that the Dr. Rosso and Hunter provided earlier. And I think it's a testament to the integrity of our data, the quality of our data, seeing as we do operate independently, but we are seeing many of the same changes in the illicit drug supply. So with that, I'll kind of dig in. Lucy mentioned a lot of this earlier, but just to kind of provide you with a field level insights on how this program works. As Lucy mentioned, we do partner with 4 different harm reduction agencies that operate independently in the district. I'm actually very proud of this program, seeing as, you know, I personally have a public health background. I'm very proud of our crime laboratory for stepping up its public health initiatives and really going above and beyond to ensure that our public health and safety stakeholders have the information at their disposal to appropriately respond to this crisis. One of the things I'll note is just due to the sheer volume of the samples that we test, this is a very robust program. Consistently, month over month, year over year, we've increased our volume. We get up to 30 samples per syringe exchange provider per week, and that averages out to about 300 or so syringes per month. And that number has steadily increased over time, which I believe is, you know, the primary driver of the quality of the data insights that we're able to provide. And I'll also give a shout out to each of our harm reduction partners for supporting this work and allowing us to present these findings, because a program like this would not be possible without them. So as you can see here, our program has been operational since 2020, which means at this point we do have a good idea of our historical trends. Many of the trends that we'll present shortly have been persistent, right? Things like predominance of fentanyl in the supply. But as Dr. Rosso and Hunter mentioned earlier, there are significant emerging trends that complicate our ability to effectively respond to this crisis. I think that's, been the overarching challenge. As soon as we're responsive to one trend, something new comes out in the supply, and none of us are perfect. So, at this point, I think, one of our biggest tools and, effectively and timely response is having near real-time analysis of the street drug supply, and that is what this program accomplishes, and it has served as a national model for other jurisdictions. So with that, let's talk a little bit about some of these novel and emerging trends. First, I'll talk about just our general communication strategy. Our data goes out on a monthly basis. It takes about, I would say, once we get a syringe, approximately 7 to 10 days to actually get a result on that syringe. That's why we call it near real time. And we aggregate this data and share it with specific stakeholders on a monthly basis. We operate on a 13-month cycle. So every monthly report indicates trends from within the last 13 months. We also do provide geospatial analysis, so we can see specifically where specific substances are appearing within the district. Another cornerstone of our communication strategy is intelligence bulletins. We issue these when we see a specific trend that's generally associated with one or a small combination of substances. So these intelligence bulletins are significantly more focused than our monthly report, and we have some examples shown here of recent bulletins that we have issued. And we have a library of many different substances. Lucy, correct me if I'm wrong, but I would say at least 1,000 substances are within these libraries. So when we receive these syringes, they're basically rinsed with a solvent and run on the instrumentation that Lucy described earlier, the GCMS. And this can basically generate a graph that allows the chemist to see what specific substances are present in these syringes. So one of the biggest trends that we've seen over the years is this increase in co-detections, right? Multiple substances being present within a singular syringe. Per my analysis in those 2020, 2021 days, you'd see maybe 5 or 6 different substances in a syringe. Now that average is significantly increasing. You can see anywhere from 15 to 20 different substances in a single syringe, which again complicates our ability to respond effectively. So some recent novel substances that we've detected that have been concerning and that we've been continuing to monitor is one is bromazolam, which is a synthetic benzodiazepine. This is something that we were initially alerted to back in July of last year, and has consistently increased its prevalence over time. As you can see from the sub-bullet, it appears in combination with many other substances, further increasing the potential for people who use drugs to overdose. Another novel psychoactive substance that we've identified recently that we have not seen before in the syringe supply is a fentanyl analog, fluorovalerylfentanyl. We detected it in April 2024. We continue to monitor it, but since then it has appeared several additional times since then. So this is one of our graphs that we include in our monthly report. It's actually one of the first graphs you'll see on the report. Basically, this is a very high-level overview of insights that we were able to glean within the past 13 months. So as you can see from the summary portion here, we analyzed close to 3,000 syringes between May 2023 and May 2024. The top 5 controlled dangerous substances we detected here were to be expected, I would say, mostly outside of dipentalone. I think that is something that is very novel, that we're seeing dipentalone in 14% of those 2,951 syringes. And I'd also think the prevalence of heroin at 10% is something that's more unique to DC, not necessarily seen across the board. That 10% is slightly higher than average. So this is, very high level kind of insights that we can use to communicate with folks working in the field, and that's easily interpretable to be able to kind of raise awareness as to what are the predominant things in the illicit drug supply. And then we can get even more specific. So we can break those insights down, of course, by drug class. So here you'll see the red line is fentanyl. It is the overwhelmingly predominant synthetic opioid in this particular drug class. The most common non-synthetic opioid was heroin that we're seeing in the used syringes. And then we're also seeing, just much like OCME, a continued presence of fluorofentanyl. It is absolutely the most prevalent fentanyl analog that we're seeing. These are just the top ones, but we do monitor many other opioids and nitazene compounds, which fall into that drug class. We're not seeing them within the top 5, but they definitely do have a presence in the illicit drug supply. And as soon as we detect a significant change, those things are communicated to our partners. And now to get even more specific than just opioids, we can break these trends down into the specific substances and what we're seeing alongside those substances. So you can see the pie chart on the left here breaks down the fentanyl analogs that we're seeing. As I mentioned earlier, the predominant one is fluorofentanyl. Fluorovalerofentanyl is slowly but steadily increasing. Like I said, this wasn't seen until just a couple of months ago, and it's already comprising 5% of what we're seeing. We have detected carfentanil and some other fentanyl analogs in several syringes as well. And then you can see with the bar chart on the right, in terms of polysubstance use, as I had mentioned earlier, we are seeing an increase. There is also an increase in the amount of adulterants we're seeing alongside the primary substance in a syringe. So as you can see here, nearly half of syringes containing fentanyl also contain caffeine, also contain xylazine. And certainly diphenhydramine, lidocaine, and phenacetin, there's not a small amount of those either. So we do see adulterants in the drug supply quite frequently, and I'll actually use this next slide to get a little bit more specific into those adulterants. So this is overall what we've seen in the last 13 months, the frequency of these different adulterants. These are the top 5, but we can see that within the major drug classes, there are specific substances that are being adulterated more than others. So with fluorofentanyl, within opioids, you're seeing greater than 80% of syringes are adulterated with some kind of non-controlled cutting agent or adulterant. With cocaine, you're seeing 44% of these syringes. In dipentalone, you're also seeing approximately 25% of syringes adulterated. One thing to note when it comes to adulterants is I do believe scheduling affects the prevalence of these adulterants. So while fentanyl was the most prevalent opioid found with xylazine, we're starting to see an initial shift. So as OCME had mentioned earlier, there is a new substance of concern that very much mimics the effects of xylazine, but has a longer duration of action, which is medetomidine. And we were alerted to this back in 2022. We were monitoring it. We had received some reports from other jurisdictions, and we continued to monitor it. We had detected it a handful of times, maybe about 9 times within the past 2 years. In June 2024, about a month and a half ago, we detected it 15 times in a single month. So this is something that we're closely monitoring. The prevalence of, once we, analyze such trends, we do communicate them to our partners so they can take action promptly. And again, just another example of the importance of having a program like this to provide more timely insights for an effective response. So I believe that's all we have for today. Please let us know if you have any questions. Otherwise, thank you all so much for listening. And again, thank you to DCHA for having us.